All right, let's go ahead and get this started. So, good evening, everyone. Thank you all for joining. We're super excited to have everyone here for today's webinar, where our guest speaker, Dr. Hutt, will be discussing mastering maxillofacial surgery planning in veterinarian workflows. My name is Jay Wethington, and I'm a software support representative here at Osteoid. And I'm just going to kick things off with a couple introductions. Firstly, I want to acknowledge and thank our co-sponsor, Dental Focus. We really appreciate all the support we've received from Jim Merritt and his team over there at Dental Focus. As we venture into veterinary spaces, having influential leaders such as yourselves by our sides has been amazing, super helpful. For everyone who isn't familiar with Osteoid, we are pioneers in the 3D dental imaging space. Our in vivo software was created in 2004 under the company name Anatomage, and since then, in vivo has become the standard in the 3D dental imaging world. In more recent years, we've expanded to include veterinary dentistry and other specialties in the veterinary space, and we're continuing to grow into that space as well. Little introduction for Dr. Hutt. He received his DVM from St. George's University College of Veterinary Medicine as part of the charter class back in 2003. And he spent 13 years as a small animal general practitioner in central New York before joining the Animal Dental Center in Maryland as a resident in dentistry and oral surgery. He became a diplomate of the American Veterinary Dental College in 2022 and continues to practice at the Animal Dental Center. Just a quick note before I pass it over. We are going to have everybody muted during the webinar, but feel free to jot down any questions you have in the Q&A box, and we'll save some time to answer those at the end. I think Dr. Up might have also put a stop slide in between the two cases that he's going to be working on for any questions that are case specific to the first case. But without any further delay, I'm going to go ahead and pass it over to you, Dr. Hutt.
All right. Here we go. Let me see if we can. So thanks everybody for joining us this evening. I appreciate you spending some time in your busy day to come out and talk about imaging and surgery and things like that. Thanks to Osteoid and Dental Focus for putting this all together. It's always fun to talk about stuff you'd like to do. With the addition of cone beam CT to our practice, thanks to Dental Focus, bringing in vivo and osteoid to help us make the most out of that imaging modality has really helped us really get the benefit of having that in the practice. So for race purposes, there's a conflict of interest. I don't work for Osteoid or Dental Focus. In fact, I'm a customer of both. We buy our software from Osteoid, and we buy our cone beam CTs from Dental Focus. And I'm solely employed by the Animal Dental Center as an associate veterinary dentist. So our goals today, we are going to talk about a couple cases, really focusing on the workflow using in vivo 7, the different views and tools, and cone beam CT imaging for surgical planning and implementation. So how do we get the information from our imaging translated onto our patient, and how do we use that information that we get from the imaging to make our surgeries more precise and successful. And in vivo is a wonderful set of tools, but really we're using some of the most common tools. So if you don't have in vivo, if you're using other software, a lot of these things are going to carry over. So in vivo is a great way to do it, but most of your softwares are going to have NPR and 3D and things like and measurement tools, and so a lot of this will be relevant. So it's not just an ad for in vivo. It also should be helpful even if you don't use the software. So we're going to talk about multiplanar reconstruction. So NPR, in vivo calls it sections. You can actually go in the preferences and change the name of the tabs if you want, if that makes it easier. You can even get rid of the tabs that you don't use, because there's lots of other more human stuff on there that's not super relevant to us veterinarians. And we'll use that to sort of measure things, help us better evaluate margins. of what we want to do surgically. We're going to talk about how to use the image capture tools to create a bank of images that we can reference quickly and easily, both for medical record keeping purposes and intraoperatively, so that we can kind of see what we did with the imaging, and then use it quickly and easily when we're in surgery. We're going to use the volume render tab or the 3D tab, and the clipping and sculpture tools are ways that we can adjust those images to see the anatomy that we want to see. We're also going to use the TMJ tab, which is again another great way to really focus in on the TMJs and evaluate those very complex structures, and also kind of capture that image or capture that information in a few simple images that are very easy to then transfer to your electronic medical record or to share and things like that, without having to sort of dynamically go through the sectional imaging every time. And then if we have time, we'll play with the superimposition tool a little bit, which is kind of fun to kind of see what you did if you have before and after scans, and you can really superimpose them and kind of see what everything looks like. So our first case is a 2-year-old male neuter domestic short hair. He presented for a severe class 2 malocclusion and a complete inability to open or really close the mouth, where he was kind of locked in a closed position. Since he was a kitten, he kind of came to the owners this way as a small kitten. He'd had some sort of unknown previous trauma, and he basically ate his food by kind of licking through the space between his jaws, but his jaws were completely fused. He had originally been, recommended referral at the time of adoption almost 2 years prior, but the owners hadn't quite got around to it. He was doing okay, so they kind of knew they were going to probably have to do something eventually, but they had put it off. And then he had an acute episode of oral bleeding. Of course, nobody could figure out from where, because he couldn't open his mouth. The bleeding fortunately stopped on his own, and he presented shortly after that for evaluation. At the time we evaluated him the first time, his PCV was only about 20%, so he really wasn't a great candidate for any kind of surgery. But we did do, a short anesthetic procedure just to image him, so we could kind of see what's going on and come up with a surgical plan. We knew we were probably going to have to do a tracheostomy in order to, properly anesthetize him for whatever surgery we ended up doing. And so he went back to his primary care. They monitored his red blood cell counts, and they came up pretty quickly. And he came back 3 weeks later for a temporary tracheostomy and a unilateral segmental mandibulectomy. And then we also extracted all of his teeth at the same time. So here he is. This was the day before surgery. His mom sent me this picture. She was very worried about him, and she wanted to make sure we knew what a sweet little guy he was. He's pretty adorable, sitting there at home, hanging out under the lamp. You can see he has a pretty severe class 2 malocclusion. He's got a really, really short jaw. And you can see his tongue kind of hangs out, and that's pretty much all he could do. He could kind of lap food just through the little space between his jaws. He had a severe asymmetrical malocclusion, so the right jaw was much, much shorter, or the right mandible was much shorter than the left mandible. You can see the left canine tooth is displaced way over. The right one is actually kind of up against the roof of his mouth, pretty atraumatically, because it's kind of mesioverted. And then the left mandible is much longer and shifted over to the right. He's got lots and lots of calculus because he doesn't have any normal chewing motion. And then, of course, that's very likely to progress to all sorts of periodontal disease and things like that. And then he can kind of just get his tongue out between the gaps between his left mandible and his upper jaw, and that's kind of how he'd been eating for pretty much his whole life. So this was when he was sedated, and we were able to do his cone beam CT with just a short anesthesia with some injectable allofaxan and flow by oxygen. So now we're going to switch over and take a look at his initial cone beam CT. So this is the the volume render tab. So this kind of I like to start in the 3D or volume render. I kind of think of it like my distance exam. I kind of look at the gross features, kind of look at the big stuff, evaluate the teeth, kind of count the teeth, look at the shape of the jaws, the shape of the skull, and kind of look for fractured teeth and sort of the big things before we really drill down into the fine anatomy in the MPR. So if we and we can in vivo we can just grab and drag to rotate the head, or we can use the arrow keys to manipulate the study. If we tip him up and get a look at these mandibles, his right mandible is extremely shortened. You can see it's basically everything's pulled over to the right. The left mandible continued to grow, but it's deviated and kind of bent. His teeth are in occlusion on that side. And then, his molar's actually all the way behind the end of the caudal maxilla because it never really grew. And then if we look at him from the backside, we use these little shortcuts at the top, which will put them into the positions. You can see the right TMJ is just sort of a mess of fused bone, very irregular. He's obviously had some sort of trauma that's healed. And the left one actually looks fairly normal. It looks like we have what appears to be a pretty normal joint space and a fairly normal looking temporomandibular joint. And then the jaw just kind of shifts over. So due to his lifelong tongue pressure, you can see that his left mandibular premolars are kind of labioverted. The tongue's kind of like tipped them over time. And that's kind of the only space he's got to get his tongue out. That's how he's been eating. And then we're kind of looking at him also to try to figure out where was this bleeding coming from. If we kind of look down through the orbit, he does have a little bit of a defect in the bone of the caudal maxilla where this left molar sits. You see it's asymmetrical. It's kind of normal here on the right side, but there is some bone loss here. And, we couldn't really see that because it couldn't get his mouth open, but there was some concern that perhaps his he had a soft tissue defect there as well and may have eroded into, the palatal artery or something like that. And that's where the bleeding was coming from. So we were going to be, kind of cognizant of that when we got his mouth open, because we're worried that there might be some bleeding or we might have to tie something off or close the defect when we did finally get his mouth open. So now that we kind of have an idea of what we're dealing with and sort of the gross appearance, we want to switch over to the sections or the multiplanar reconstruction and kind of see what he's got going on there. And one other thing I had actually meant to point out, that's a good thing to remember about volume render or 3D, is that if we look at the bone of the palate, it looks like it's gone. It looks like he has no palatal bone. And of course, we can adjust that a little bit. We can play with the rendering and we can make that bone come and go, but I can't really make it solid there. And that's one of the things you have to be really careful about when you're using a three-dimensional render, is that you can change the rendering quite a bit and you can make it look like there's more or less bone, and that can affect your perception of periodontal disease. That can affect your perception of all sorts of bony lesions. So you want to be very careful. You want to avoid making diagnosis of the quality of the bone solely from 3D. You don't want to diagnose periodontal disease solely from your 3D renderings, because you're going to get misled because the software has to decide when to render bone and when to leave it out, and it's somewhat subjective, and you can actually change that by using different filters and sliders and things like that. So we always want to go back to the NPR of the sections to kind of have the sort of definitive word on whether or not we think bone is present or lost when we're trying to evaluate whether the bone is really there or not. And because there's sort of a finite point where both the resolution of the cone beam CT itself, whether it can see the bone or not, and then how it's rendered. But looking at that palatal bone, as we kind of scroll through the study here, we can actually see that it is pretty much intact. So we're at the level of the fourth premolars and back, and it's thin, but it's there. And so you can see that defect right here, where that left first molar has definitely caused some atrophy of the bone. Again, cone beam CT is not ideal for looking at soft tissue, so we can't really say if there's a soft tissue defect there. And cats are difficult. They really are, the size of them, especially a small cat like this, is really right at the resolution of what cone beam CT, can do. And so, this is one of those areas where it also helps when you're looking at cat teeth and to still do dental radiographs. You really still need all the information you can get about these teeth and things like that. But for, looking at structures that you can't get good radiographs of and getting a three-dimensional idea of what's going on, you really can't beat the spatial resolution of cone beam CT. So it's a combination of kind of putting all that stuff together. So a couple other things that are sort of, germane to what we want to do is we know we want to take out this right mandible because we think the left mandible or the left TMJ is functional. And if we can remove a portion of the right mandible, we should be able to get his mouth open and he should be functional, which means we're going to have to cut through the right mandible in the caudal area. And normally there's an artery in there, a mandibular artery. We can see the mandibular canal right here as we scroll back, and I'm always looking at the other views to kind of reference where I'm at the same time. That's the beauty of multiplanar, is you're looking at a two-dimensional slice, but you always have three-dimensional references to tell you exactly where you are. And as we move back through the slices here, and look, the mandibular canal is still there. We're back at the level of the first molar. In fact, if I flip around the 3D, we can see exactly where we are in the first molar. It's still a fairly normal looking mandible. And then we get into the area that's probably injured and where the healed injury was, and the normal architecture and anatomy just kind of goes away. So on the left side, this all looks pretty normal. We're getting into the coronoid process. We still have a mandibular canal. As we go back, we should start to see the opening of the inferior alveolar, which we'll see on the other side. Should be back here. Actually right there. So that's where the artery goes into the mandible on the normal side. And on this side, we just have kind of just a lot of bone. And you can see the beginning of it, but then it sort of peters out. So it looks like we probably don't have a patent mandibular artery behind the molar here. And that becomes very germane for when we go to section this, we don't have to worry about dealing with that artery like we would in a normal mandibulectomy. So that actually makes life a little bit easier. If we stay right behind this molar, we can probably approach the entire thing ventrally and buccally and not have to worry about severing that artery or dealing with it when we get the jaw out. So the other big question, if we go to all the trouble to take out this right mandible, is it going to help him? Is he going to be able to open his jaw? Obviously, we'll get rid of these teeth. It will give us access to the maxillary teeth, which are problematic, and will allow us to extract those. But then what's going to happen on the left side? Are we going to be able to get the left side open and things like that? Because he does have some problems on the left side as well. He's actually got some already. He's only 2, but he's already got some tooth resorption, which we can see right here in the left maxillary second premolar. We can turn our cursor back on. We want to just zoom right into one spot and bring all the windows to the same place. So we have a nice resorptive lesion in that left maxillary third premolar. So that's obviously a painful lesion and that would need to come out. But right now it's completely blocked in by the lower mandible. So it's kind of a small fish to fry for this guy, but it's just another reason that, we need to do more than just get his jaw open. We probably need to get most of these teeth out. So when we want to evaluate his TMJ for patency and functionality, we have the TMJ tab. So there's lots of tabs, and a lot of these I don't use because they're for people, but there's a number of good tools. So the TMJ tool allows us to kind of focus in and look at both TMJs at the same time. Most of the time it is sort of designed for people. So most of the time when you first open it up, it looks like this. It doesn't make a lot of sense. It took me a while to figure it out. But we'll start by adjusting it into reorientation. So we're going to click on that little adjustment, the little happy face, hit adjust, and that's going to take it in. Now we've already rotated everything when we first set up our scan, but we're going to move these green bars to put the head inside it, and that's going to bring it into view. And so now we have views, and we basically have these two boxes. We can actually set them up to be symmetrical. And then we have an axis. So if we line up the axis on midline, it will set the boxes up symmetrically on either side. And then I'm going to scroll through this dorsal view until I can kind of see a TMJ. And then I'm going to line these boxes up along the axis of the joint so that this yellow line, and I can actually make the whole thing bigger. So if I just press Control and slide, that allows me to make it larger. And so now I have my axis right through the joint. The symmetry brings you the same thing on the other side, and it basically shows me where the joints are. Each one of these green lines is an individual cross section through that line that's showing me a cross section of the joint as we go through. And I can line them up symmetrically in basically the same orientation on both sides. And so you can compare left to right, this one to this one. So on the left side, we have a pretty normal looking condyle and a normal fossa. We have a normal joint space, and we can go through. Up here, we can set the width of the boxes, the intervals, the slice thicknesses, gives us a nice little 3D view of the joint as well. So we can kind of keep that for reference over here. And so you kind of have a complete documentation of the joint. And anytime I want to document something, I can either go up here to the View tab and hit Capture to Gallery and select my views. If I want to do the whole thing, I just hit OK. It'll automatically name it. I can put some comments. I hit OK, and basically it's going to go put it in the Gallery tab. So now I have a captured image that will stay the same. And will populate in the gallery that I can save. So if I want to evaluate the entire TMJ, I can scroll my little green lines to the other half of the TMJ on both sides, kind of keeping them in the same position. And again, if you don't want to go up to the view, you can just hit Control G and bring up that capture tab again. So again, I'm going to do the whole view. So basically everything in this box is going to get saved. I hit OK. It now gives me a number next to it. So this is another TMJ view, and it puts it in the gallery. If I go over here and check my gallery, here's my first image, and it's fixed. Here's my second one. And so I can do that 2-3 images. I've mapped the whole TMJ. I can then export these as JPEGs or another file type that's really easy to import into your electronic medical record. It's really easy to send to a radiologist, another clinician, or anybody else that you want to send it to, or really easy to just put in a folder so that you can tab through them when you're sitting chairside, when you're doing surgery to reference it. And you can do this with any view, so it's not just the TMJ tab. You could do it with any view, throughout. So, I mentioned before that cats are a fairly, they're small and they're kind of at the limit of resolution of a cone beam CT. I wanted to use this opportunity to just showcase something that our Zoran VetCat IQ does, and a lot of other machines can do this as well. It's called a region of interest rendering. And so if you have something that you need really fine detail that you want to look at, the standard scan for the machine that made these images, the Zoran VetCat, is 0.3 millimeter slices, and they're isometric in every direction. So every scan is the voxels are the same size in every direction. But if you need more detail, you can actually go back to the machine itself, and you can select a portion of your study, and then you can re-render it down to as small as 0.07. And so that's what I did to kind of look at these TMJs again, just to kind of make sure that I really had a good assessment of them. And so now this is the region of interest. And so we've taken that and we've just taken a smaller part of the scan. We've basically done just the jaws and the TMJs. We've re-rendered it. So the VetCat puts out a whole new stack of 500 some slices. That's just the small area that I selected, and renders it down to 0.07 millimeters. So basically about a quarter of the thickness of what we started with. And so now we can see, and I've already kind of set this all up so we can look at it, detail through these TMJs as we roll through is even finer. And as we go through the whole left joint here, you can see that that joint space is continuous all the way through, and that overall the structures all look happy, and it looks like they're going to be functional. Now, again, we don't know if there's, fibrosis. We don't know if there's going to be any kind of soft tissue issue, but as far as, the bony structures go, this TMJ should work. And so if we alleviate the ankylosis, or if we alleviate the fixation from the right side, we should be able to open up the left side. So that's basically the plan. We go back to the volume render on this region of interest. You can see, we'll do the bone render. You can see this, we don't have the whole skull. We've selected part of it, but you can also see the rendering is just much smoother, and you just have a much finer detail. So a lot of conventional CT and some cone beam CTs have the ability to re-render at a finer resolution that's even a higher resolution than what their sort of native resolution is. So, if you're looking for more detail, you might be able to go back to the machine like we can with our VetCat and get that resolution. But that means a whole nother stack, a whole nother in vivo file. So it's somewhat time consuming to do that. But if you really want to look at that detail and kind of see what it looks like, it's worthwhile if you really need it. Because, if we compare that to the original one, we definitely have a much finer level of detail. And so you can see it's a little bit smoother, and you get a little bit more detail. All right, so we're going to switch back over here to PowerPoint. So basically, after looking at all that, we came up with our surgical plan, which is we're going to need a temporary tracheostomy for anesthesia. We're going to do a mandibulectomy. We're going to split the symphysis, and then we're going to remove the right mandible at about the level of the mandibular first molar, and that should allow the left TMJ some mobility. That'll give us access to the right maxillary dentition. If we can get the mouth open, that'll give us the access to both the left maxillary and mandibular dentition. And then we decided that, once we get in there, whether the teeth are healthy or not, we were going to extract all of the teeth. Because of the malocclusion, he really had no functional occlusion between any of the opposing teeth. He wasn't going to be a functional chewer. He already had some tooth resorption. He already had some, periodontal disease. Even with his mouth open, he was not going to be the easiest cat in the world to intubate in the future. He likely was not going to be able to, go back to his regular veterinarian for routine dental care, and things like that. And so the likelihood that maintaining teeth for this cat, if that was even possible, was going to have additional expense and things like that. And so the benefit of trying to keep teeth that would be not very useful to the cat, and expensive to maintain and things like that, and just likely to cause him problems and not a lot of benefit, the decision was made to get his mouth open, get the teeth out. If he had any palatal defects, removing the teeth would allow us to bring in buccal flaps to correct those, and kind of fix everything all at once. So hopefully he would never need any oral surgery again in the future. So that was kind of the surgical plan. So here he is after his temporary tracheostomy. So he's ready for surgery. This is his intraoral approach for the mandibulectomy. I did still tie off his middle and caudal mental arteries, although they really didn't have much blood supply. And on the right there, you see a variety of different piezotome tips. So the piezotome is really your friend for these kind of surgeries where access is very difficult to get to. And so we used a piezotome to make the caudal cut in the mandible just behind the first molar. And to section that part of the mandible. And in a cat, you can pretty much split the symphysis with a scalpel blade most of the time, remove the soft tissue attachments, and then remove the piece. Because it didn't look like there was any appreciable mandibular artery at the level of the first molar, we could make the entire approach pretty much laterally and ventrally and not have to worry about getting to and tying off that artery. So that was kind of that was nice. Here's the mandible after it was removed, and there's just a little bit of it. So we did take him back and do a post-cone beam, and we'll show you what that looks like. I think he kind of looks like a jack-o'-lantern now. So here he is. You can see his mouth is already open wider. Extraction of the the left mandibular dentition also just gives him more of an opening. I mean, those labioverted teeth weren't doing him any favors anyway. But now we can see, we went through the mandible right behind the molar. Turns out he did have a little bit of a mandibular artery left. It was pretty atrophied. It was small, and fortunately, it was right. It was kind of the last thing we went through right after the section came loose, so it was pretty easy to manage the bleeding. My original plan was to kind of cut more perpendicularly, but because of the soft tissue and his cheeks and things like that, the access was much more difficult. I had contemplated doing a commissurotomy, but I really didn't want to make any more soft tissue holes in this cat than we already had, and so we were still able to get that completely intraorally, and then just had to deal with a small, almost sort of vestigial mandibular artery after the piece came out, and then completed the extractions and put everything back together. So, and now his, fortunately, as soon as this section was removed, the other TMJ seemed to move just fine, and everything seemed very functional. So he did really well. Recovered nicely, went home the same day. This is him right before we recovered him. So you can see all his teeth have been extracted, everything's sutured up, his mouth's open quite a bit more. Obviously, he still has a really short jaw, but a lot more functional than he was before. He came back 2 weeks later for a recheck. He went home and ate dinner, according to his mom. He's playing, super happy. I think the worst part about it was just trying to keep him quiet because he's a 2-year-old kitten. So he was kind of bouncing around like a madman, having a grand old time. His tracheostomy had completely healed. In the meantime, he still had some sutures, but basically his extraction sites were healing, and he was happy. Mom and dad were really happy, and he was doing very well. And that was him in his recheck. So I think he looks a lot less derpy and a lot more intense. I think he's much happier now that he can open his mouth. So I don't know if anybody has any questions before we move on to the next case. But that was our first case. And you can also just throw them in the chat if you have them, and we can get to them at the end as well. I don't see any so far. So we will move on. Either I'm very thorough, or most of you are just have this in the background while you're doing dishes and making dinner. So
it looks like we actually did just get a question in right after you checked. They said, do you consider endoscope guided intubation, 3 mm diameter, as an alternative to avoid temporary tracheotomy? Have you encountered any complications with temporary tracheotomy, such as aspiration pneumonia or stenosis? And can you close the TIM trach since you only keep the tube for a short time?
So, I mean, that's a common discussion, I think, amongst, dentists and oral surgeons and things like that, I do think a lot of people spend an awful lot of time trying to intubate these guys, to avoid having to do a tracheostomy. I mean, I worry about that too. You spend a bunch of time where you don't have control of the airway. A tracheostomy is pretty quick and relatively easy, but it can have those complications. So I think they both have pros and cons. I think the benefit of not having the tube in the mouth, where you already have a difficulty getting in there, you don't have a lot of space to work. It's a very tight opening and things like that. I usually lean towards the temporary tracheostomy. I'm comfortable doing it. We can do it quickly, and you can try to do the intubation with a scope and things like that. And if you can't get it, you still have to do a tracheostomy. So if you have an anesthesiologist or you have a scope and you're super comfortable with that, it's a great way to go. But I've had good success, with doing the temporary tracheostomies. I do actually leave them open. And this is a young, healthy cat. So, and they do tend to heal well on their own. Obviously, you read the client the riot act with, please don't give the cat a bath, things like that. We usually, anytime I extract canine teeth, I almost always, or total mouths, I always send him home with an e-collar. And of course, this cat, I didn't really want to send him home with an e-collar riding on his tracheostomy site. So that was a little bit of a conundrum, and we ended up sending him home with no e-collar. But mom was on top of it, and he did really well without him. But that's definitely, I think it's a question that everybody has with these cases, and it's sort of a conundrum. Do you spend the time and effort and try to get them intubated, or you just go right to the tracheostomy? So I think it's depends on your individual comfort level and the level of support you have and things like that. So I don't think there's a right or a wrong answer. But I think they're both valid ways to do it. And like I said, I've just been successful doing it this way. And I don't have the equipment and I don't have a lot of experience doing it the other way. So I guess that's also so it would probably be much harder for me. Move on to our next case, and we can answer more questions. I see more questions coming up, but we can get to them at the end. This is the next case, a little bit longer. So this is a 2-year-old female spayed mixed breed dog. She presented for rapidly growing right caudal maxillary mass. She initially presented to, we have 4 locations, 3 in Maryland and 1 in Pennsylvania. She initially presented to one of our other locations and saw one of my colleagues for imaging and incisional biopsy. It was kind of an unusual presentation. And so they didn't go right to excisional biopsy, especially in such a young dog. The biopsy came back, a spindle cell neoplasm, suspected to be a type of invasive tumor of young large breed dogs, rising palatal to the maxillary fourth premolar or first molar, as yet unreported in the veterinary literature. This is actually the second tumor with this exact same presentation and biopsy report that I've seen personally in the last 3 years. I think we've had 3 in the practice. One of my other colleagues saw one, again, identical presentation, identical biopsy. I think of it as sort of like a fibrosarcoma light, or like a very, very wimpy fibrosarcoma. But that being said, it definitely can progress, and it is somewhat invasive. So basically, it seems to be a tumor that you want to get out with a decent surgical margin. But if you do that, there's a good chance, that there will be a surgical cure. I do think the pathologist is kind of collecting cases to write up a case series, but it hasn't been published yet. So, but we have seen a few of them. So here she is, lovely dog, very sweet. So because of some scheduling and other issues, the initial presentation ended up being like 5 weeks prior to the I think the owner actually had some scheduling issues. It seemed to really it was hard to get a hold of her, and we had a difficult time, and that was one of the reasons why we ended up going to a different office, and most of the time we kind of stick with the same doctor, but for a variety of reasons, it ended up seeing one team for the initial and then came to see me for the definitive surgery. The nice thing about staging procedures, and a lot of times we do end up seeing things the same day and doing more biopsy with curative intent type stuff, because it just saves time and it saves the client money, or it's financially beneficial. But if you're not really sure what you're looking at, then staging things is obviously the way to go. You can get a histopathologic diagnosis. You can do your imaging and really spend your time to figure out what you want to do, and kind of really plan your surgery. So this was a case that we had histopathology in hand with plenty of time to stage it, and lots of time to look at the imaging and kind of come up with a surgical plan. So this really didn't look like much. I mean, this is a 2-year-old dog, so it's young. The mass itself was sort of like a smooth, almost like kind of I would describe this sort of pillowy. If you looked at the dental radiographs, you'd be hard pressed to say there were any bony changes at all if you didn't know they were there. But you could definitely see them on the cone beam CT. So this is what it looked like. This was at the initial presentation. So on the left is prior to surgery. You can see the incisional biopsy was taken from the middle of the lesion in the picture on the right there. I think it would be very easy if you at a glance to say that, in the old parlance, this is an epulus, this is a POF, this is some sort of benign fibrous hyperplasia or something like that. and not be too worried about it, or just debulk it, or something like that. That would be, I think, an easy mistake to make, especially if you didn't have a cone beam CT, especially if you weren't doing dental radiographs and didn't see that there was some invasive bony changes. But fortunately, with cone beam CT, it's pretty hard to miss the bony changes. I think X-rays, it would have been easy to miss. So let's take a look at that original cone beam. So again, I like to start in the 3D or the volume render. Like I said, it's kind of a distance exam. And so that was on the right side of the dog. Here we are on the right side of the dog. So sort of buccally, the spacing between the teeth is normal. The quality and character of the bone is normal. I don't see any major deformations. I don't see any broken teeth. I don't see anything that seems to be seriously out of order. If we flip over and take a look at I'm sorry, that was if we look at the left side, also pretty unremarkable. Nothing kind of jumps out from this perspective. We can kind of look from the front, kind of scan around, see if there's anything that kind of piques our interest. And so not much going on. The mass is obviously on the palate, so that's kind of where we want to go. So this is where we're going to use some of the other viewing tools. So if we kind of put the palate facing us, obviously we've got the mandibles, we've got the endotracheal tube are all kind of in our way. So the clipping tools are nice. You can enable clipping, and that allows you to remove a portion of the view in different directions. And so you've got, a sagittal will cut it in half. Axial will do it top to bottom, coronal front to back. You can change the amount. I usually do the full half. So in this case, the axial, there's a custom clipping that I think just came out in 7.2 that allows you to actually change the plane, so you can kind of adjust it however you want. So that's kind of fun. I haven't played with that too much yet, but I guess it's new. But if we do the axial, that allows us to remove the mandibles. If we click the flip button, it allows us to remove the maxilla. You can see it takes the other side. So it just gives you the other half. We flip back because we want to look at the maxilla. Get back in position. So now I can just very quickly remove half of the scan and look at what I want to see. So I can make it bigger and smaller and center it. So if we're looking at the palate, we can see that there's definitely visible changes in the bone, right? This all looks pretty normal. In the area where we saw the mass, we've got these hits in the bone. We have some, evidence of bony lysis, bone loss, things like that. But, if we want to see the whole teeth, then the tube starts to come in. And so again, getting back into some of these tools before we get into the case too much. So in addition to clipping, which is just kind of in a single plane at a time, we also have the sculpting tools. So if I turn the clipping off, say we want to get rid of the endotracheal tube, I can use the sculpting tool, and there's a freehanding sculpt and a linear sculpting, a polygon. If I turn this on, I can click and drag and just draw a shape around it. And anything in that shape goes away, which is kind of fun. If I want to remove the tube in a more awkward location, I can use a combination of clipping and sculpting. So I turn on the clipping, I'll do it coronally, and I'll do maybe a 40 millimeter slab, because now as I roll it back, I can isolate the tube, and anything that's clipped away won't get removed by the sculpting tool. So I can actually isolate the part of the tube I want to remove and remove it. And then I can go back further and take out more. So again, if you're preparing for a lecture and you want to make really pretty pictures, you can spend a lot of time doing this and take out the tube. You can take out all sorts of stuff. If you just need to get it out of your way without cutting into the relevant anatomy, that might happen if you just use the clipping tool. If we use the polygon, sometimes it's easier. You just click each spot on the line and make a polygon shape. When you're done, you double click. And if I click outside the circle, everything goes away. Inside the shape, just what's inside goes away. And again, as I go back further, I can take out more. If I then turn the clipping off, Now the tube is gone in the back. Put it back in position. Clip it axially, and now I can have the tube out of the way, and I can really see kind of grossly where the changes are. But again, like we talked about before, I'm not going to do all of my margin evaluation in 3D, right? I know that there's bony changes. I know roughly where they are, but I'm not going to make the full extent of my margins based on this 3D alone. Because again, if I start to play with my sliders, I can make that look better and worse in different places. And so I don't want that subjectivity to interfere with my assessment of where I think the tumor starts and stops. And again, this is a cone beam CT, so we really can't tell much of anything at all about the soft tissues as well. Now, in for maxillofacial stuff, there's not a lot of soft tissue, so bony margins are often good enough to kind of tell you where to cut. But if you're worried about something that's likely to really invade the soft tissue, then you might need to think about conventional CT. So that's a whole nother discussion about when you should use cone beam versus conventional CT. We probably don't have time to get into this evening. But for margin evaluation, a lot of times I will go back to the NPR and I will look slice by slice in the different views, and I'll start to look for bony changes. So for example, once we kind of get back, and then I'll use the 3D to kind of always remind myself of where I am. And then I'll go slice by slice, like in this transverse, I'm seeing some bony change here. And so if I want to figure out what is the most rostral extent of this lesion, I'll go slice by slice rostrally, and I still see changes. It's normal over here. I've got lysis of the bone here. I keep going slice by slice until I don't see it anymore. And the NPR is much more objective than the 3D until I convince myself I really don't see it anymore. And I feel like right about here, kind of at the palatal root of the fourth premolar, is where the bone goes back to normal. And so, I don't see anything all the way across. So this is kind of my most rostral margin. And I can repeat that process caudally, and I can repeat it to midline and kind of determine exactly where I want to go. Same thing with the deep margin. We can look at it in all the different views. Ultimately, what we decided the margin is that this is a very superficial bone invasion, and that we want to take out the caudal maxilla, including the teeth, from about the second premolar all the way to the caudal extent of the maxilla. But because it's so superficial and because it's only palatal, there's nothing in the buccal bone. There's nothing that appears to penetrate the bony, the plate of bone, that we can probably spare the infraorbital foramen. But because we don't know much about this tumor and because it's associated with the teeth, I always worry about whether or not it might invade the periodontal ligament space and things like that. And so if I'm going to take the teeth, I try to take the entire alveolus. And so, it can be a little bit tricky to try to take the entire alveolus of the, the caudal teeth, the premolars and molars, but spare the infraorbital so that and the nasolacrimal duct, right? So we've got that here and there. If we go ventral to the infraorbital, then we might end up cutting through the tooth roots and then having to extract them. And then we might leave part of the alveolus behind, which could theoretically have tumor cells in the ligament. If the tumor does that, we don't know much about this tumor. Maybe it could do that. If I get the whole alveolus, I feel pretty confident that we have a full layer of bone between this tumor. And if I can do that and still leave the infraorbital, then we keep the blood supply, we keep the nerve supply. We don't mess with the nasolacrimal duct, and it's a less invasive surgery. But basically, we have to kind of thread the needle. So originally I went through, and if we go and look at the gallery, originally, start up here, we basically went through and measured from the cemento-enamel junction along the outside buccal bone using our curved ruler, the distance from the cemento-enamel junction to the end of the root, and then the cross-section at each point at how thick the bone was at each point along the way to kind of map out where we wanted to put our cuts so that we could get the entire tooth, the entire alveolus, and take out that whole plate of bone without actually removing the infraorbital artery. And so we did that for each tooth, each root, and then made those measurements right along. And then we kind of came out with sort of a tentative margin. And you can apply all this, put it in the gallery, save it as a JPEG, put it in a folder, and then you can flip through these images chairside. And so we had kind of done all this before the day of surgery on the original scan, but then 5 weeks went by. So we actually went and did it again on the day of surgery just to make sure there was, to deal with any progression. And so let's switch back over here. So on the day of surgery, we decided to, because again, 5 weeks had passed, we decided to repeat the bone scan to look at the bony margins, and also to kind of change up the scan a little bit because that the caudal portion of the palatine bone was a little bit suspicious as it kind of heads towards the pterygoid bone. And that was kind of right at the end of the field of view of the initial scan. So because we'd already fully evaluated all the other teeth and everything, on the day of surgery, we kind of moved our field of view back. And so we did a more caudal field of view to really include the entire pterygoid, the caudal palatine bone. We propped the mouth open to let the tongue hang away from the palate, because even though cone beam CT doesn't see soft tissue very well, it definitely can't distinguish between the tumor and the tongue if the tongue is laying on the tumor. If the tumor is surrounded by air, you can actually see the outlines of it, so you can make your life easier if you position the animal in such a way that at least like you get that interface between air and palatal tissue or air and tumor tissue, so you can kind of at least grossly see where it is, even if you can't discern the different types of soft tissue within the mass. And if that seems like it's a lot of scans, we did a scan and then we came back and then we had to do another bone scan. And you actually have to do, if you want to do contrast, you actually have to do two, a soft tissue scan and a soft tissue scan with contrast. If that seems like a lot of radiation, it's still far less radiation than you would get with a single round of conventional CT. So cone beam CT uses way less radiation, which is why it doesn't have the contrast resolution of a conventional CT, along with a bunch of other reasons. So, I've talked to radiologists about that and the relative levels of radiation, even though our machine yells at us when we do 3 scans in a row, it says you're using too much radiation. It's still way less radiation than a conventional CT with contrast. And so if it gives you better information and it allows you to do a better surgery, it's probably worth the slightly higher dose. And so in this case, again, because we don't know much about this type of tumor, we did decide to do a soft tissue scan, which is a separate scan at a slightly higher dose of radiation using a different software algorithm that increases contrast more than a standard cone beam bone scan, but not to the level of a conventional CT. And when you have that, not all cone beams can do it. You can then do injectable contrast at the same time using that same soft tissue mode, and then you can compare them side by side. In this particular case, the soft tissue, the tumor did not seem to, it had basically minimal to no contrast enhancement. And when you do the soft tissue scan, you'll notice that you really lose some of that really fine spatial resolution that you get in the bone scan. So not to dwell on it too much, this is a side-by-side. On the left, you have a soft tissue scan right through the tumor at the level of the first molar with no contrast. And on the right, you can see the exact same level, same scan immediately after injecting some Omnipaque, IV contrast. And with the cone beam, the timing seems to be you want to get the contrast in as fast as you can and run the scan as quickly as possible, because again, it really, it doesn't last very long. And you can see the lingual vessels, you can see, everything's a little bit brighter, but there's not a huge difference in the tumor itself. If we zoom in on it, between the pre-contrast and the post-contrast, maybe there's a vessel running through it that lit up a little bit, but it doesn't seem to enhance too much, and it doesn't seem to show any bigger margins or anything like that. So, again, what we can say about it is it doesn't seem to contrast enhance on a soft tissue cone beam. Whether it would be more information from a conventional CT, that would be a good question, but we don't have one. So if we go and look at the day of cone beam, here we are. This one's already been clipped and sculpted, and the time is getting away from me. But basically, we have very similar, but I do think even on the 3D, it's a little bit more noticeable on the caudal palatal bone here. And so I do think we probably want to move our margin back from what we had originally, talked about. If we go back to the NPR, we'll kind of go step by step a little bit on just how to make those measurements that I had showed you in the gallery before. It's really simple. So, our we're going to start at the second premolar. Let's make this a little bit smaller. I'm going to start at the second premolar because it starts right around the distal root of the third premolar palatal root there. Our buccal height is going to be sort of at the bottom of the infraorbital. So the infraorbital itself is kind of our first landmark. We can actually slide our piezo. We can lift up the infraorbital neurovascular bundle and slide our piezotome right underneath it. And that'll be kind of the beginning of our cut. And then as we move back to the mesiobuccal root of the fourth premolar, we can take our multi-point ruler and start at that cemento-enamel junction, follow the bone up to the height of where we're past the root, double click. And that tells us that we're about 16.7 millimeters. We can take our straight ruler, and it will tell us if we want to go underneath it, it's going to be about 6.8 millimeters. If we're a little bit off and end up in the infraorbital, at least on that lateral wall, it's going to be about 2.5 millimeters. And either one would be fine. As long as we stay above the roots, we're going to get this whole plate of bone. If we cut here, and then we just end up having to sort of break the perpendicular plate of the palatal bone there as it goes back. If we go all the way underneath it, as long as we get around the roots, I think we're still going to have our margin. And so then we can, Control G, throw that one in the gallery to save later. Our workstations actually are in a central doctor's office that looks at all of our, all of our operating tables. And that's set up with computers that have graphics cards and big processors and stuff like that. So we kind of do all of our reading in at one office station. And then we just export these gallery images as JPEGs onto a server, and then we can pull them up chairside at any of the 4 surgery tables that we have in the hospital. So that's kind of how we deal with managing the images. So we only open the studies once, we work on them in one place, and then we export all the images and just go through them as single images, and it's kind of much easier that way. And so that's why we use the gallery a lot, chairside, and you can just have one of your technicians or assistants or whatever kind of tapping through these images for you to kind of remind you of what these measurements are. So as we go back, we can make that measurement for each root along the way and kind of map exactly where we want to place our buccal cut, how deep it needs to be. And then you can either, I use those little paper curved rulers to follow the contour of the bone, exactly what these measurements are. And then just, either score the bone with a burr on a high speed or with just with a periosteal elevator, make a mark, and then come back with a piezotome and make that very precise cut to get exactly the piece of bone you want and basically uncap the ventral aspect of the infraorbital canal. It's sort of like the opposite of a dorsal rim excision in the mandible. It's kind of like a ventral rim excision. And that actually works very nicely. And so that's what we did here. We also, went back and went all the way to midline. And then the last part is, these bony changes do go past the end of the maxilla into the basically the end of the palatine bone as it goes towards the pterygoid. And a lot of times when you do these caudal maxillectomies, you end up sort of breaking this off, and where it breaks is not always where you want it to. And so just to make sure we got all the way back, we ended up going back and using the piezotome to go underneath and make a horizontal cut underneath here to make sure that we got as much of the palatine bone as possible all the way back to the beginning of the pterygoid bone to make sure that we got that whole shelf with all those bony changes. And that actually worked out pretty well. We'll look at the post. because I do want to have time for questions. So here's our post. There's the left side. On the right side, we can see we kind of followed up right underneath. So you can see the infraorbital canal there. And then as we go back, we got that nice little notch out of the palatine bone going back to the pterygoid. If we go back to our clipping, you can see there's a little bit of a dog leg in the palatal cut there. So it's not going to mess with our margin. It's just not pretty. So figures that's the case I want to present. That'll just have to keep me humble. But we can see we took this little notch out and then we stayed below. We didn't leave any tooth roots behind and we were able to completely spare. So there's your infraorbital canal kind of uncovered but intact. And then we've got the whole thing out. And then superimposition tab was we can basically take this post and superimpose it with the pre. And so it kind of shows you the section that was removed. And we're getting a little short on time. So if you have in vivo, you can kind of play with that yourself, but you see the pre is in blue and it kind of shows you the section that was removed. It's kind of fun to show the owner. You can say, hey, look, this is what we did. This is where we removed it. You can see all the roots are effectively removed. They're included in the section that was removed. And then everything was put back together. Minimal bleeding, maintain the blood supply to all the soft tissues near flap, maintains the nervous supply, don't get anywhere near the nasolacrimal duct. And this dog did, went home an hour or two after surgery and did very well. And so of course we sent that out for another histopathology, and that this is just kind of summarizing what our surgical goals were because that bony invasion seemed to be very limited, both palatally and superficially bone. That's why we kind of went with this more conservative approach to kind of get out all the teeth, but to leave as much of the the structure of the maxilla as possible. So there's the section after it was removed. This soft tissue margin, I was a little uncomfortable with that. That was a little bit close. So I did go back and remove a margin of soft tissue after this came out, just to make sure that we had a good margin all the way around. And, but you can see underneath that, we've got the full plate of bone. There's no teeth sticking through, no roots or anything. And it pretty much came out exactly as we had kind of planned it on the original bone scan. So that is the tumor before on the left. You can see the scar from the original incisional biopsy, and then that's the closure after the caudal maxillectomy on the right. And then it's just a mucogingival flap closure, or just a mucosal flap closure. And we already went through that histopathology. So again, it confirmed the same thing. There was no evidence of neoplasia in the buccal tissues. Anywhere between 9 and 15 millimeter margins all the way around. Interestingly, the invasion was limited to no more than 3 millimeters deep into any of the bone. And so it looked like it's completely excised and local recurrence is not expected. So looks like it was a successful surgery. It's sort of the kind of, I think, the most limited approach we could do and still hope to, get it out and not have it come back. And so it's not expected to metastasize. It's not expected to get back. And then this is the post-op picture. So this was about, an hour post-op right before she went home. And actually, I didn't have any pre-op pictures. So the first picture I showed you was also a post-op picture. So she actually looked pretty happy when she went home. All right. Any questions?
Yeah, it looks like we have a couple. We had somebody ask, why do you not initially scan at a higher resolution instead of having to reconstruct the case again later at a higher resolution?
So the sort of native resolution of the scanner is 0.3 millimeters. So that's like what it scans at. And then if you want to go to a higher resolution than 0.3 millimeters, it's not actually scanning at a higher resolution, it's reconstructing. And you typically have to choose a smaller field of view. So you can only do a region of interest. So you basically have to you have to focus in on a smaller area of the scan. And it's so you're basically sacrificing field of view to get a higher resolution. It also takes more time, it's more memory. You're building a whole nother DICOM stack. And so if you wanted to do that on every case, it would be it would be like storage intensive, time intensive. And most of the time, 0.3 millimeters is great. Like for a conventional CT, if you get 0.5 millimeters, you're really happy. And a lot of times you're looking at 1 millimeter and stuff like that. So the spatial resolution of a typical cone beam at 0.3 millimeters is actually really, really good. And so it's just, if you want more than that, if you're looking at, really fine structures or a really small animal, then you have to go back and re-render it. And it is like it's a kind of a computer generated rendering, so it's sort of the software is massaging it down to that resolution. It's not like the native resolution of the machine. I'm not a physicist, but that's my understanding of it.
Makes sense to me. Let's see what else we've got. Have somebody ask, did surgery commence immediately after you acquired the CBCT? How much time did you spend on developing the plan on this case? And I believe this was referring to the first case.
Yeah, so with both cases, both cases I did have I did have an initial scan before. And so typically, most of the time we do our scans at induction. It's the first thing we do. They actually get induced in the CBCT room. The VetCat is mobile. We actually can roll it right up to the table, but we have 4 tables and we often have multiple doctors working. So we usually keep the cone beam in a designated CT room that's like lead lined and everything, so everyone else can keep working, and we bring the patients to it. So they get induced in there, they get scanned, and then they come out. If they need their teeth cleaned, they have their dental cleaning, they have their dental radiographs. Everybody gets full mouth radiographs pretty much. And so they get cleaned, they get radiographed, they get photographed, so the technicians do all of that. And so that gives the time it takes to do that, basically gives us time to, look at the scans and come up with our surgical plan. And so most of the time that works out pretty well. I think, between cleaning and radiographs and stuff like that, it's often like 45 minutes to an hour potentially that we have to play with the scans and things like that. And then we can kind of sit down and do an anesthetized oral exam and stuff like that. And if we need to, they can be under anesthesia while we figure that out. But most of the time we can kind of come up with our whole plan and the time it takes to get them cleaned and radiographed, photographed, and then ready for surgery.
Great. Okay. And the last question it looks like we have was somebody asked, does your imaging protocol for oral maxillofacial surgery cases include both pre-op and post-op CBCT scans?
So I do like to do post-op CBCTs a lot. And I think it varies a little bit. We have 5 diplomates in our practice, and we all do quite a bit of maxillofacial surgery. I don't know that everybody does post-ops. I just like to see what I did. When I started my resident, I think we got our first cone beam in 2020. And so I've kind of had it for like half of my dentistry career so far. And so I think, being able to see exactly what you accomplished compared to what you think you accomplished, you know what I mean? Because these are tight spaces, these are complicated cases, and we're trying to get millimeters of bone here and there and stuff like that. So going back and having that post-op CBCT to see, did you get exactly what you think you got? What did you do well? What did you not do well? It's a great learning experience. In our practice, we also have residents and stuff. So it's a great teaching opportunity for them both to see like what, when they do stuff or when you do stuff, like what worked and what didn't work and what you tried to do and what you actually accomplished. It also is a great baseline for, to judge recurrence. I mean, is something growing back? Use the superimposition tool. We have our post-op scan. They come back in 6 months, 9 months, and a year. You can literally superimpose their skull on the top of it and see how that's changed. So I think it's super useful. And so, if we have the time and the patient's stable under anesthesia and things like that, I do it a lot. A lot of times I don't even charge for it, because like I want to know, I consider it like professional development, to make sure. And I think when we first got it, we hardly ever did it. And now I do it almost every time, at least for the bigger cases. I mean, I don't do post-op cone beam CTs for perio cases. We still do post-op radiographs, of course. But for bigger ectomies and things like that, definitely, I think it's really helpful, both for just to again to kind of see what you did and make sure that you accomplished what you thought you accomplished, and as a baseline for future evaluation of that patient.
Beautiful. Okay. It looks like that's all the questions we had. Oh no, actually, we got two more just came in. Um, Somebody asked, can the in vivo software be used with a fan beam CT? Um,
It
I
should
would,
work. Yeah, it works pretty much with any. I mean, you probably know better than I do, Jay, but it should work with pretty much any sectional imaging that works, that uses a DICOM stack.
yep.
So, I mean, I had an MRI of my own head, and I actually threw it in there and looked at my own, which you really shouldn't do before you get the radiology report. If like, don't ever look at your own imaging before they tell you it's okay, because I'm not used to looking at human MRIs, and I was a little worried until they told me it was fine. So, but yes, you can look at MRIs, you can look at conventional CTs, pretty much any DICOM studies you can use it on. So the typical stuff that we do, it should work fine.
Yep. Agree with Dr. Hutt. Just as long as it's a DICOM stack, in vivo will have no issues with it. Um, and the last question we have says, do you think the infraorbital bandle, I'm not familiar with that term, so you may have to look at that one
Mhm.
yourself, Dr. Hutt, but is a facial plane that might help with the margin of the mass?
Um, I think it can be a fascial plane that might help with the margin of the mass. And so if I think I need it, I would take it. But like I said, in this case, like with it, because I knew what this tumor was, and I knew that similar tumors have been really, really superficial, that I was pretty confident that the bone was going to be enough of a margin, because it was so superficial. And then just making sure that we got the entire, alveolus, all the tooth roots and everything. I've done this procedure before where I've actually taken the fascial sheath of the infraorbital neurovascular bundle as a fascial plane as well, and just left the nerve and the artery. So I've actually like removed that as another layer when I've done this before, just to give me one more layer, for it was actually for a papillary squamous cell carcinoma, that the owner really did not want a big maxillectomy. So he wanted to spare as much as possible. And he was willing to come back if we didn't get margins. So we uncapped the infraorbital and then actually removed the fascial sheath as well as another fascial plane. So, but that is a concern. And I would only do it for, if it was a mass that I knew wasn't super invasive.
Beautiful. Great answer, Dr. Hutt. It looks like that's all the questions we have, though. So I want to thank you again, Dr. Hutt, for putting together your presentation. It's always great working with you. And as always, thank you to all of our attendees as well. We really appreciate you taking the time out of your schedule to join us. And hopefully you found some of the information here informative, interesting, as long as you took something out of this. And please be on the lookout for any sort of follow-up emails that'll contain a survey for CE submission requirements. We will also be including a special offer from Osteoid for attending the webinar. So if you're interested in learning more about the in vivo software as your 3D imaging solution, please feel free to reach out to the team with any questions. We're always happy to help out and do any sort of education we can manage to. Um, but I hope everybody has a great evening. And once again, thank you, Dr. Hutt, for all your time put into this.
Thanks a lot, Jay. Thank you, Osteoid and Dental Focus. And thanks everybody for listening. I appreciate you coming and spending time with us tonight.